Well, welcome everybody to, I don't know what number this is now, but the February version of our Excel in your future PT career. Today, I am super excited because I get to take some of your time. Usually I just introduce some folks and get to listen. Today, Irene Lee and I are going to be walking you through caseload and also patient management and treatment planning. So we've got a lot of really cool stuff planned for you today. Before I get into it, as you can see on the screen, if you are going to CSM, just a quick plug, that's coming up next week already. Come join us at booth 3125. Say hello, mention that you have seen the Excel and PT series, and we usually have some pretty cool swag. So we could probably hook you up with some good stuff. All right, so come see us. Other than that, we're going to get into it today. Get this out of the way. Perfect. All right, before I get into my content, I want to talk a little bit about the presenters that you're going to hear from today. Like I mentioned, Irene Lee is joining us. She's from our Motion PT group. Motion is a part of the Confluent Health family. She's a director of the Clinical Education and Mentorship Program at Motion. She's also board certified in sports, an HSS rehabilitation credentialed advanced hip specialist, certified in kinesiotape, certified in myofascial decompression, and RYT 200-hour yoga teacher, which I didn't know until we started this, and that is super cool. Irene brings a wealth of experience, and it also serves as the head physio medical provider for the Old Blue Rugby Club. She works with many rugby clubs and has also served on the sports medicine staff at the U.S. Olympic Training Center in Colorado Springs, Colorado, to assist Team USA. So lots of really cool knowledge. Irene is very experienced and also just a really good human. So I think you'll learn a bunch from her today. This is me. I'm Allison. I am the Senior Director of Talent, Learning, and Development at Confluent Health. My job is to make sure that our clinicians and our leaders and really all of our employees at Confluent Health have what they need to develop and also remain sustainable providers in healthcare. So sustainable providers means they want to wake up every day and actually do the really good work that they're doing, hopefully preventing some burnout and also providing excellent care in the process. I went to Youngstown State University and moved to Texas to do my residency, proceeded on to get my orthopedic specialty, my pain specialty, pelvic health specialty, and then made a little bit of a left turn and ended up in executive coaching and learning and development. So I get to talk to you about caseload today. So we're going to jump right into it. This is the hot topic. If you spend more than 5 minutes on PT social media, you'll realize that there's a little bit of a divide, or at the very least, there are a few camps around caseload. Some camps are very one-to-one centric, that it is very important that you spend all of your time with one particular patient. Often that looks like once an hour. And then you have another camp that is not that. That may be interested in a higher caseload or more than one patient overlapping, that sort of thing. And today, I am posing the question of caseload, is it really the conversation that we need to be having? Do we really need to have these camps? Or is there something else at the heart of it that we really should be talking about? So before I get started, I want to hear from you. These webinars, I can't see a thing. All I can see is what's on my screen. So it's nice to know there are real humans on the other side. So if you are live joining us, please scan that QR code and answer this question. Is one-on-one care superior to higher caseload that requires some overlap? Now, I want to add a little bit of a caveat to this. We're not talking about the extremes here, right? We're not talking about an average of 20 patients a day or anything crazy like that. What I'm talking about, sort of middle of the road, one-to-one care, no overlap versus some overlap in patient care. So again, scan that QR code, answer. I will give you a minute or two. This is my first time using forms for this, so we will see if it works. Okay, we got A lot of it depends. I added the it depends in there. We have a 1 response. There we go, 2 responses. I added the it depends because that seems to be the PT school motto. When you're in PT school, you get a little bit frustrated. I know I did that every time we had a question, our professors were like, yeah, it depends, which is true. There's a lot of nuance in what we do. All right, responses are coming in. Cool. And no judgment. Also, like tell the truth. Whatever you feel right now, this isn't connected to any names or anything like that. Like I said, I can't see you. All right, so majority says it depends. Some say, yeah, absolutely, right? I think that's pretty much the standard. Again, when you look at social media and also as you're going through school, all signs are going to point to, okay, yeah, this one-to-one thing, that seems to be where it's at. So I appreciate everyone weighing in there. Very cool. All right. Cool. So it looks like a little bit of tie between it depends and yes. I'm going to go to the next one now. Let me. Oh, no. Oh boy. Well, forms. I thought you were great. Maybe not. Here we go. All right, let's do the next one. So same deal, scan that QR code. And when considering that same question about caseload that I just asked, what considerations do you take into account? So, and you have multiple selections, you can select them all, you can select some, but when you are thinking, okay, is one-to-one care superior, or what about this caseload thing? How am I making the decision I am around what matters? What of these things are you choosing? And it could be patient outcome. Yeah.
We can't see your screen.
Oh, good. All right, let's do this. Yeah, it seems like Forms decided to backfire on me a little bit. Let's do that. How about now?
Got it.
Cool. All right, scan that QR code. Again, when considering the question of caseload, how many patients to see and when? Is there overlap or is one-to-one better? What considerations do you take into account? And you can select any and all or none of them as you go through. So I'll give you a minute to kind of look through those. Again, patient outcomes, satisfaction, clinician burnout, referral source perception, financial consideration, patient expectation, ability to provide evidence-based care and safety. Cool. And select all that apply. So yeah, this is pretty common in the literature too, when they look at, okay, what matters when we're making these decisions about caseload or our perception of caseload. A lot of times we're saying, okay, I want to see patients in this way because I value patient outcomes, patient satisfaction. I don't want to be burned out. I don't want to go home every night and have 1 to 2 hours of notes to do. So that's a big part of it. Referral source perception might be a part of it. Financial consideration on either end, we can talk about that. Patient expectation, ability to provide evidence-based care. Sometimes we link those things, and safety. Good, awesome. And you'll see again where the research is really pointing towards is we really care about that patient satisfaction, right? We want that patient to say, yes, this was worth my time, and rightfully so, right? And patient outcomes usually second to follow. Cool. Thank you, everybody, for indulging me on those 2 things. Let's see if Forms decides to work. Sure doesn't. Okay, let's get out of that again. Every time. Well, you live and you learn. All right, we'll go back to this again. All right, so let's talk about some research. So I want you to imagine that you are a research subject, and in this particular design, you get to watch 2 videos. The first video is of a patient in a hospital room, and the physician comes in and sits next to them. And for 9.5 minutes, they have a version of a consultation/treatment. right? They go through the evaluative process, they ask questions, they chat with the patient, they come up with what's going on, they come up with a game plan, a plan of care, they kind of go through the whole thing. Right? And imagine yourself and where you're in the room, you're sitting, they're sitting next to you, and it looks something a little bit like this. Then I want you to picture a different scenario, scenario 2, which is still 9.5 minutes long. And the things that happened in the previous one when they were sitting next to each other and chatting and going through the evaluative process, all of those things happen. But this time, the physician is standing and the patient is sitting. Everything else is generally the same, and the time frame is 9.5 minutes. So this study was actually done, and they looked at the difference between patient perception and what was actually happening based on those two different scenarios. What happens if the physician is sitting versus standing? All other things kept the same. 35 patients, so 51% of those patients blindly preferred that the physician was sitting. They liked that one better. 23% preferred standing, and 18% said, either way, I'm good. Here's the interesting part though. Patients perceived that their preferred physician was more compassionate and spent more time with them. So if they liked the sitting physician, they thought that that physician spent more time with them and was more compassionate. If they liked the standing one, during the standing, they thought that one spent more time and also was more compassionate. That's pretty wild, right? That even though all factors were the same, both physicians, 9.5 minutes, both physicians generally kind. But the difference was if they met their preference on how to be communicated to, their perception was they spent more time. Statistically, more patients prefer that the physician start in sitting and then move to standing, which is also really interesting. Our ability to shape the perception of what time is and how people perceive value is much higher in our communication than it is by the hands on the clock. Let's talk about another study. This one's a large one. So 461 encounters of overweight or obese patients with 40 primary care physicians. And this included 320 encounters in which weight was discussed. So what they did was they calculated the time spent with the physician and coded all communication using motivational interview treatment integrity scale. So they went through and they actually coded the way that the physician was communicating with the patient, and they were looking at how long the physician was spending with that patient. At the end of the survey, or at the end of the research study, the patients completed a post-visit questionnaire in which they reported the estimated duration of the encounter. So the patient, without fully knowing how much time they spent in the room, reported how much time they thought they spent in the room. They also reported how rushed they thought the physician was. And then on the other end, the physicians reported how rushed they actually felt. Here are the results. Patients estimated encounters to be longer than they actually were by an average of 2.5 minutes when physicians used reflective statements when discussing weight. Again, it's like the standing versus sitting preferred. The patient is going to estimate in their brain and perceive that you are spending more time with them when you are compassionate and when you use reflective statements from motivational interviewing. In the reverse, the patients estimated that the encounter to be shorter if physicians did not use reflective statements. So that was a big piece of the communication. And again, you're perceiving, okay, what's actually happening here versus what am I perceiving is happening? And we have a lot of control over that. Also interesting, physicians felt rushed in 66% of visits. Patients didn't perceive it at all. So oftentimes we feel like we're running around like a chicken with our head cut off. We feel like we're being rushed or we are rushing. And in reality, the patient, they're not picking up on it, right? They don't realize that, or they're not computing that in their brain. Also, just interesting, internists were perceived to be more rushed than family physicians. Lots of theories there. Okay. But again, it goes back to when we talk about our patients expecting time. Is it actually that they expect time, or they expect quality interaction that makes them perceive time? So let's go back to our initial question, which is there a correlation between time spent, minutes, actual minutes on the clock with patients one-on-one, and patient outcomes, patient satisfaction, burnout, referral to PT, financial gain, ability to provide evidence-based care, and safety? The answer is no. Again, I want to go back and add the caveat of there's always an it depends. There's always a really extreme example one way or another. But when we look at the evidence that we actually have, we have no evidence to suggest that patient outcomes, patient satisfaction, and the length of time that we spend with that patient are significantly connected or correlated. So if it's not about minutes on the clock, then what is it actually about? In a systematic review, they looked at patient satisfaction and if the patient would return, and what factors mattered to that patient. If we go back to that original survey at the beginning that you all filled out, most of you said patient satisfaction, that's the #1 reason I'm making my caseload decisions. The next is patient outcomes. The next is evidence-based care. So if I look at it from a patient satisfaction standpoint, what matters to patients is the PT answers their questions. The PT explains their treatment. They listen. They're courteous. Coming in at #5 is spends enough time, but that's the one that I want you to challenge, in that their definition of enough time is a perception of time. You can spend all the time in the world with them, but if you don't use reflective questioning, if you don't match the preferences of communication and presence for your patient, they'll still perceive that you're not spending a bunch of time with them, right? And you can leverage it in the other direction as well. They also care about detailed instructions, advice, sound advice. If the office staff is courteous, if it's clean, if there's up-to-date equipment, right? And you can see all the rest, and I'll share this so you have it. So my challenge to everybody is to get out of the mindset of one-to-one care or not one-to-one care is better than the other. And instead have the conversation and get yourself out of the grip of the hands of the clock and ask these questions. How can I best connect with my patient? How can I be clear in my communication? And how can I apply evidence-based treatment to this case? And when you ask yourself those 3 questions, you may find that it's not about time at all.